warning.
Yeah, no dramatic alarms, no visible trauma. One minute you're just sitting at your desk, and the next your entire circulatory system just hits a catastrophic wall.
It's terrifying. I mean, it is the absolute definition of a high-stakes, invisible threat, and navigating it requires, literal split-second decision-making.
Which brings us to our mission for this deep dive. We are looking at a really high-yield medical summary based on the newly released 2026 AHFIRA and ESSER's guidelines for treating a pulmonary embolism.
And if you work in emergency medicine, or even if you just want to understand how modern medicine tackles one of its most complex vascular emergencies, this is for you.
Exactly. These sources act as a literal cheat sheet for saving lives.
Yeah, and looking at the sheer volume of acronyms and algorithms in this document, I mean, it can seem really dense at first glance.
Oh, totally.
But if you strip away all the rigid formatting, what these guidelines actually do is tell this high-speed story of calculating risk, mastering timing, and choosing the exact right weapon for the specific physiological battle happening inside the patient.
So let's break down that battle, because before a physician can jump into any of the fancy high-tech interventions we're going to cover, the patient simply has to be kept alive.
Right, the absolute basic.
The clock is ticking the second they hit the door, which leads directly into the initial management protocols, the first 5 minutes.
The stabilization phase.
Yeah.
And the guidelines really emphasize bypassing the complex stuff initially just to secure those basics. So the ABCs, airway, breathing, circulation.
Right.
If the patient's oxygen saturation, their SpO2 drops under 90%, you supply supplemental oxygen, you get IV access immediately, and you get them on an ECG monitor to track exactly how the heart is handling the event.
Because the heart is suddenly trying to pump blood through this massive roadblock in the lungs. And the sources note that if the patient is entering shock, meaning, their blood pressure is just plummeting, you have to support the circulatory system instantly.
Yeah, you have to prop them up.
So the first line choice is a vasopressor called norepinephrine. It acts on the alpha receptors to clamp down the blood vessels and basically force the pressure back up.
Or if the blood pressure is holding but the heart just isn't pumping enough volume, they suggest dobutamine to help the heart muscle squeeze harder.
But reading through these initial steps, there is this massive bolded warning that seems totally counterintuitive. Like, it literally says, avoid excessive IV fluids.
Yeah, that warning trips up a lot of practitioners.
I bet.
Because it goes completely against standard resuscitation reflexes.
Yeah.
I mean, if a patient's blood pressure is crashing in almost any other scenario, say trauma or sepsis, the immediate instinct is to open the IV fluids wide open.
Right, fill the tank.
Exactly, fill the tank and bring the pressure back up.
But taking a step back and looking at the mechanics of a PE, giving fluids seems a lot like dealing with a blocked pipe in a house. Like, if your plumbing is completely clogged, which is what a massive clot in the pulmonary artery is doing, pouring more water down the drain doesn't clear the blockage.
It just backs up.
Right. It just causes the sink to overflow.
That is a perfect analogy.
Yeah.
And taking that plumbing analogy into the anatomy, the sink that is backing up is the right ventricle of the heart.
Okay.
The right ventricle is built for volume, not pressure. Under normal circumstances, it pumps blood into the lungs, which act like this spongy, low-resistance network. It's an easy job.
Super easy.
But a pulmonary embolism creates a sudden, massive wall of resistance. So if you aggressively pump IV fluids into the patient, all that extra volume rushes into the right ventricle and just slams into that wall.
So the fluid has literally nowhere to go.
Exactly nowhere. The right ventricle stretches. But because it shares a wall, the septum with the left ventricle, as the right side balloons out from all that excess fluid, it physically bows into the left side.
Oh, wow.
Yeah, it squishes it. The left ventricle then can't fill properly, which means it can't pump blood to the rest of the body, and the blood pressure crashes even harder.
That is wild. So you actively cause right ventricular failure and worsen the shock by trying to help with fluids.
Exactly. You have to thread the needle of supporting circulation without overflowing the system.
That is a terrifying cascade. And the sources highlight that managing this early stabilization instantly dictates your path forward through early risk stratification.
Right.
You are immediately categorizing the patient as high risk, intermediate risk, or low risk based on that right ventricular function and their blood pressure.
And establishing that baseline dictates the entire treatment algorithm. Once you know how much strain the heart is under, you have to move to the foundational treatment.
Because you can't just leave the clot there.
Right, you have a clot sitting in the pulmonary artery, you have to do something about it.
Which takes us to the absolute bedrock of the guidelines, anticoagulation. And the mandate here is totally unambiguous. You must initiate anticoagulation immediately once a PE is suspected. Well, assuming the bleeding risk is acceptable.
Yeah, you don't even wait hours for a confirmatory CT scan if the clinical suspicion is high enough.
Yeah.
You just move.
Right. You have to stop that clot from propagating so the body's intrinsic enzymes can eventually break it down.
Exactly. And for stable patients, the preferred medications are DOACs, direct oral anticoagulants. Apixaban and rivaroxaban are really highlighted as the frontrunners here.
They've basically replaced warfarin for most people, right?
Oh, absolutely. Mostly because of their predictable pharmacokinetics.
Yeah.
They directly inhibit factor zeta in the clotting cascade. They don't require constant blood monitoring. And, they don't have the vast category interactions that warfarin does.
The sources do note that 2 other DOACs, adoxaban and dabigatran, are also used, but they require a parenteral or injectable bridge first. Like, you have to give the patient initial heparin before transitioning to those specific pills.
Right. Usually low molecular weight heparin is preferred alongside a drug called fondaparinux for that.
Okay, so those are standard for intermediate and low-risk pathways. But then the guidelines detail IV unfractionated heparin, UFH. And looking at the indications for UFH, there's a contradiction that really stands out to me.
Oh.
Yeah, the sources say you use this IV heparin for patients with hemodynamic instability, or planned surgeries, or severe renal failure, and that all tracks logically. But they also list very high bleeding risk as a primary reason to use it.
Huh.
I mean, if a patient is already at a high risk of bleeding out, choosing a continuous IV blood thinner over just giving them a standard pill seems vastly more aggressive, doesn't it?
It does. Looking purely at the delivery method, an IV drip definitely seems aggressive. But the decision to use IV heparin isn't about hitting the clot harder. It's about maintaining absolute minute-to-minute control over the patient's coagulation status.
Control that you lose if you just hand them a pill.
Exactly. Think about it. When a patient swallows a DOAC, that medication enters the digestive system. You have committed to that dose.
Right, it's in there.
It is circulating in the blood for hours. If that high-risk patient suddenly starts hemorrhaging internally, you cannot unswallow the pill.
Wow, yeah, it's essentially a runaway train at that point.
You're strapped in until the liver and kidneys clear it, or, you have to scramble to find very specific, incredibly expensive reversal agents.
But an IV drip of unfractionated heparin acts totally differently.
Totally differently. The guidelines highlight it for its rapid reversal capabilities. Because the drug is continuously fed directly into the vein, its half-life in the body is incredibly short, like around 60 to 90 minutes.
So it's basically a dial.
It's exactly a dial. The second a patient starts bleeding, you just turn off the IV pump. The blood thinning effect starts plummeting almost immediately.
And if you need to neutralize it faster,
you push a widely available antidote called protamine sulfate, which binds to the heparin and reverses it instantly.
So you use the IV because it acts as a clinical safety switch. You protect a fragile patient by keeping them on a really short leash.
Precisely.
Now, once the patient is successfully anticoagulated, the sources break down exactly how long they need to stay on these meds. And it seems to depend entirely on the nature of the initial clot.
It does.
Like if the PE was provoked by a major surgery or a severe trauma, meaning there was a transient reversible risk factor, the treatment duration is typically 3 months.
Yeah, the logic being that the underlying trigger is gone, the surgical wounds have healed, the patient is mobile again, so that hypercoagulable state has resolved itself.
But if it is an unprovoked PE, meaning it happened without any obvious trigger or trauma, the guidelines mandate at least 3 months, but they strongly urge physicians to consider extended or even indefinite treatment.
Right, assuming their bleeding risk remains low.
And for patients with active cancer, the guidelines require long-term anticoagulation for as long as the cancer remains active, because malignancies just fundamentally alter the blood chemistry, right?
Yeah, cancer makes the blood constantly prone to clotting, which is a massive risk factor. And if a patient has recurrent blood clots, regardless of the trigger, the recommendation is almost always indefinite anticoagulation.
Okay, so anticoagulation is the foundational strategy. It stops the clot from getting bigger. But what if preventing growth isn't enough?
Right.
What if the patient is actively crashing in front of you? This moves us into what the guidelines basically treat as the nuclear option, systemic thrombolysis.
This represents a massive escalation in the treatment algorithm. You're moving from simply pausing clot formation to deploying chemical agents that actively blow the clot apart.
The guidelines label this a Class I indication for high risk or massive PEs. We're talking about patients with persistent hypotension, meaning their systolic blood pressure is stuck below 90 despite everything you're doing.
Right.
Or they're in active obstructive shock, or they have literally gone into cardiac arrest because the embolism has completely halted forward blood flow.
The right ventricle has failed, the blockage is absolute, and you are just out of time. You need immediate restoration of pulmonary blood flow.
And the weapon of choice here is alteplase, also known as TPA.
Yep.
The standard protocol is 100 milligrams given IV over 2 hours, though the notes mention that in a cardiac arrest scenario, hospitals might push it much faster using accelerated protocols.
Oh, well, yeah.
But reading about the efficacy of alteplase brings up a really blunt question. If this drug physically dissolves the clot that is killing the patient, why is it reserved strictly for the absolute highest risk cases?
Yeah, it's a fair question.
Right. Like, why not administer this clot buster to every patient who presents with a PE and just clear their lungs instantly?
I mean, it sounds like the perfect silver bullet, but the physiological trade-off is absolutely terrifying. Thrombolytic drugs like TPA do not have a targeting system. They work by converting plasminogen to plasmin, which is an enzyme that degrades fibrin.
And fibrin is the structural mesh of a clot, right?
Exactly.
Yeah.
But TPA doesn't just travel to the lungs and politely dissolve the one rogue clot blocking the artery. It systemically degrades fibrin everywhere in the entire body.
Which means it dissolves the good clots, too.
Precisely. Human bodies are constantly forming these microscopic hemostatic plugs to seal up tiny tears in our blood vessels, just keeping our circulatory system pressurized and intact.
Sure.
If you introduce systemic TPA, you destroy all of those vital seals simultaneously.
Wow. Okay, that perfectly explains the absolute contraindications listed in the sources. You cannot give this drug to someone with a previous intracranial hemorrhage or active internal bleeding, or an ischemic stroke within the last 3 months, an intracranial tumor, or major recent head trauma.
Because if a patient has a weakened or recently injured blood vessel in their brain, and you destroy the microscopic clot that is currently keeping it sealed, they will suffer a catastrophic intracranial hemorrhage. The risk of the patient spontaneously bleeding into their own skull is so incredibly high that the danger completely outweighs the benefit, unless the PE is actively causing circulatory collapse.
which is why the guidelines are so adamant. Routine systemic thrombolysis is not recommended for intermediate risk PE. The bleeding risk is just totally unjustifiable.
Right. It is only held in reserve as a rescue thrombolysis if an intermediate patient suddenly starts crashing.
That is the crucial distinction in the 2026 update. You do not deploy the nuclear option unless the patient's hemodynamics demand it.
Exactly.
But that creates a really terrifying gray zone.
Oh, yeah.
What does a clinical team do if a patient is crashing? Meaning they desperately need the clot gone, but they have one of those absolute contraindications.
It's a nightmare scenario.
Like, imagine a patient who suffered a major car accident which caused the clot, but they also have recent severe head trauma. You cannot give them systemic TPA without causing a fatal brain bleed. But you also can't just let the right ventricle fail.
So you move to the next tier of the algorithm: precision strikes and physical safety nets. If you cannot safely deliver the drug systemically, you have to bypass the systemic circulation and just go in physically.
The sources outline a fascinating technique for this called catheter-directed therapy, or CDT.
Yeah, this is where interventional radiology or cardiology steps in. They literally thread a catheter through the vascular system, navigate it right up into the pulmonary artery, and park it directly inside the actual clot.
So instead of flooding the entire body with TPA, they deliver a fraction of the dose locally.
Right, catheter-directed thrombolysis.
The sources also mention mechanical or aspiration thrombectomy, which uses tools on the catheter to physically fragment the clot or essentially vacuum it right out of the artery.
And the mechanical advantage here is massive. By targeting the clot directly, use a vastly lower dose of the thrombolytic drug, which drastically reduces the risk of major bleeding elsewhere in the body.
That makes total sense.
And whether you are dissolving it locally or vacuuming it out, it results in a rapid drop in pulmonary vascular resistance, which instantly relieves the pressure on that failing right ventricle.
So the sources indicate CDT for high-risk PEs where systemic thrombolysis is contraindicated, or systemic drugs were tried and just failed.
Right.
But what if a catheter isn't enough, or the patient's anatomy just doesn't allow for it? The guidelines keep escalating to an even more dramatic physical option: surgical pulmonary embolectomy.
Yeah.
This involves literally opening the chest to extract the clot.
It is the most invasive option on the table. The patient has to be placed on cardiopulmonary bypass, meaning a machine temporarily takes over the work of the heart and lungs, while a cardiothoracic surgeon opens the pulmonary artery and manually pulls the obstruction out.
That is intense. And the indications for this are as intense as the procedure itself. Massive PE with absolute contraindications to thrombolysis, failed thrombolysis, a large central embolus, or imminent circulatory collapse. But there's one specific indication in the notes that is incredibly specific: a clot in transit across a patent foramen ovale.
Okay, that is a physiological nightmare scenario right there.
Explain that one.
So a patent foramen oval, or PFO, is a small, flap-like opening between the right and left upper chambers of the heart. It naturally exists while a fetus is in the womb to bypass the lungs, but it usually seals shut after birth.
Okay.
But in a portion of the population, it never fully closes.
So if a blood clot travels up from the legs into the right side of the heart, and instead of going into the lungs, it manages to slip through that tiny hole.
It crosses from the venous system directly into the arterial system. A clot in transit means it has been caught on imaging, physically stuck halfway through that hole.
Oh, wow.
If it breaks free and completes the journey to the left side of the heart, it will be pumped directly out to the body. If it goes to the brain, it causes a massive ischemic stroke.
Jeez.
In that scenario, you cannot risk trying to dissolve it slowly. You have to go in surgically and retrieve it before it dislodges.
Historically, putting a patient with a massive PE through open heart surgery sounded like a desperate last resort with pretty grim outcomes. But the sources highlight a really optimistic shift. Mortality for surgical embolectomy is actually much lower now in experienced centers than historically reported.
Yeah, it's a highly viable option on the algorithm now. It is really a testament to how far cardiopulmonary bypass techniques and postoperative intensive care have evolved.
So there's one final physical safety net detailed in the guidelines, and it's designed for when you need to stop a clot, but you absolutely cannot use any form of blood thinner, not even locally: the inferior vena cava filter, the IVC filter.
Right. And this relies entirely on mechanical trapping rather than any chemical alteration.
The inferior vena cava is the massive main vein that carries all the deoxygenated blood from your lower body back up to your heart and lungs. If a patient has an acute PE or a deep vein thrombosis in their leg, and they have an absolute contraindication to anticoagulation, like say they are actively bleeding from trauma, the guidelines allow for the deployment of an IVC filter. Functionally, it is exactly like putting a wire strainer over the drain in your sink to catch hair before it ruins the plumbing.
I love that visual. It is literally a small umbrella-like metal cage that is deployed percutaneously inside the vein.
It doesn't treat the underlying hypercoagulable state. It doesn't stop new clots from forming in the deep veins of the legs, but it acts as a physical barricade, catching those clots before they can shoot up into the pulmonary circulation and cause a fatal embolism.
Exactly. The guidelines also indicate IVC filters for patients who are suffering recurrent PEs, despite already being on maximum therapeutic doses of blood thinners.
Right.
But there is a strict caveat attached to this intervention. They're not recommended routinely. And if a retrievable filter is used, it must be removed as soon as the patient's bleeding risk decreases enough to safely restart anticoagulation.
Because leaving a metal cage in the body's main venous highway indefinitely can eventually cause the vena cava itself to thrombose and clot off right.
Precisely. You do not leave foreign hardware in the vasculature unless the alternative is certain death.
When you step back and view this entire landscape, the sheer complexity of the decision-making is just staggering.
It really is.
You're weighing DOACs against continuous IV heparin drips. You're debating systemic clot busters that risk catastrophic brain bleeds against catheters and open chest surgeries. You're looking at a patient who might be totally stable or one who is actively dying in front of you.
It is a profound web of intersecting risks. Do you accept the risk of a fatal hemorrhage to save a failing right ventricle? Do you risk putting a hemodynamically unstable patient on a bypass machine for surgery?
Which brings us to what might be the most vital structural update in the guidelines. With all these competing physiological risks, the 2026 AAACC guidelines explicitly recognize that no single physician should be making this call alone in a vacuum.
Right.
They strongly recommend the utilization of a PERT, a pulmonary embolism response team.
This is the institutional mastermind group. When a complex or high-risk PE case hits the ER, this multidisciplinary team is activated simultaneously.
The sources list the specialists involved, and it is a massive brain trust. You have emergency physicians, cardiologists, pulmonologists, intensivists from the ICU, interventional radiologists, cardiothoracic surgeons, and hematologists, all of them analyzing the exact same patient profile in real time.
And this really reflects the broader overarching theme of modern critical care. We are moving away from siloed decision-making.
Like the Avengers assembling at a moment's notice.
Basically, yeah. By bringing all these experts to the table, the peer facilitates the rapid, synthesized selection of the exact right pathway on that complex algorithm. The cardiologist evaluates the right ventricle, the hematologist weighs the bleeding risk, the interventional radiologist assesses catheter viability, and the surgeon determines operative risk.
And together, they look at the risk stratification and collectively execute the plan.
Exactly.
To distill this entire deep dive down for you, the sources provide an exam pearl that perfectly summarizes the baseline algorithm. If a PD is diagnosed, you anticoagulate almost everyone immediately to prevent propagation. If the patient is low or intermediate risk, they get blood thinners and careful monitoring. But if they are high risks crashing, in obstructive shock, you use IV unfractionated heparin and deploy immediate systemic thrombolysis to melt the blockage.
And if that systemic TPA is contraindicated due to bleeding risks, or if it fails to restore hemodynamics, you bypass the systemic route and go physically with catheter-directed therapy or surgical embolectomy.
And finally, if blood thinners are entirely impossible from the very start, you deploy the mechanical IVC filter.
It really is a masterclass in risk management and physiological troubleshooting.
It truly is. But as we wrap up, we've spent this entire deep dive looking at how to battle a clot once it's already formed, right?
Yeah.
Once the plumbing is already blocked and the heart is failing, looking at all this medical logic and all these incredible interventions, there is an underlying question that still lingers.
There is. When you look at the varying treatment lengths for provoked versus unprovoked PEs, a really unsettling mystery emerges. With a provoked PE, say, from an orthopedic surgery or major trauma, the cause and effect is obvious. The endothelial damage and immobility trigger the cascade.
Right.
But for the unprovoked cases, the ones that require indefinite treatment because we can't identify the trigger, the most haunting question remains the body's hidden tipping point.
We don't actually know what sets it off.
We don't. What invisible, microscopic threshold is crossed in our cellular makeup that suddenly decides to turn our own lifeblood into a solid hazard, entirely unprovoked?
That's crazy to think about.
One moment the system is flowing perfectly, maintaining that delicate balance of hemostasis, and the next, for reasons we still cannot fully detect on a hematological level, the blood triggers its own clotting cascade.
Wow.
It's a reminder that while our PERT teams and endovascular treatments are incredibly advanced, the deep foundational mysteries of human physiology are still calling out to be solved.
The diagnostic algorithms might be perfected, but the muddy waters of the human bloodstream still hold some profound secrets. Something to think about the next time you feel your own pulse.